Good afternoon, everyone. This is Dr. Vichar, and welcome to the Alleviate's webinar series. Today, we'll be discussing an important topic, common nerve entrapments and of the lower limb and its treatment. This is me, Dr. Vichar. I'm a consultant pain specialist at Alleviate Pain and Spine Center, Bangalore, former consultant anesthesiologist at Astra Aadhar, Kolhapur. These are our clinics and the OT setup. So overview of what we will be discussing today is lateral femoral cutaneous nerve entrapment, sciatic nerve entrapment, and fibular nerve entrapment. After which we will also be discussing about the basic presentations of how on sonoanatomy and sonopathology of how a nerve will be looking. So I have divided the topics into etiology, signs and symptoms, diagnosis and treatment. So first, lateral femoral cutaneous nerve entrapment. Anatomy, purely a sensory nerve, originates from the lumbar plexus, ventral rami of L2 and L3. At the ASIS, divides into anterior and posterior divisions, supplying the anterolateral and lateral thigh respectively. Entrapment may happen when the LFCN exits the pelvis or pierces the inguinal ligament. So the etiology, the characteristics of nerve entrapment were first defined by Bernard in 1878, and neuralgia paresthetica, the term which it was coined by Roth in 1895. The exact cause is unknown. Common between the age 30 and 60 years. Incidence is 4.3 per 10,000, and common in 1/3 of the children. This is again in osteoid osteoma, although we feel that it may not be there in children, but 1/3 of the children suffering from osteoid osteoma do have this. So this becomes one of the comorbidities. And the other comorbidities, commonly, it can be with a few of them I've listed: carpal tunnel, pregnancy, obesity, hip osteoarthritis, and diabetes mellitus. Yeah. Sorry. The cause can be spontaneous. So it can be intrapelvic, extrapelvic, mechanical, or metabolic. So in intrapelvic, it can be pregnancy, tumor, fibroids. Extrapelvis, it can be seat belt, tight garments, which is quite common. So tight belts also, and obesity. Mechanical, prolonged sitting and standing. Work related, that means metabolic, hypothyroidism, alcoholism, lead poisoning, diabetes. But the greatest risk is obesity and BMI more than 30. So iatrogenic, again, a very common thing which they do is a bone grafting and pelvic osteotomy, THR, renal transplant. All of this can be one of the cause. Iatrogenic cause. So signs and symptoms are majority are unilateral, maybe bilateral in 20%. Sensory loss, paresthesia, this aesthesia are present. Hair loss because of constant touching and handling that area. There can be a hair loss which you may see on physical examination. Prolonged standings, walking, and hip extension may be painful. Tunnel sign may be elicited near the inguinal ligament. So there's something called as pelvic compression test, which is got 95% sensitivity and 93.3% specificity. It's an illustrated diagram in which the patient is lying on the unaffected side laterally, and we give pressure over the pelvis for about 45 seconds, and a temporary relief of the patient's symptoms may be seen. So differentials, again, for all these lower limb entrapments, you have to rule out these three very important things: that is lumbar plexopathy, high lumbar radiculopathy, and peripheral neuropathy. So diagnosis is neuroimaging of pelvis and the lumbosacral spine. Electrodiagnosis may play an important role in neuralgia paresthetica, but technical difficulties can be encountered in obese patient. EMG is usually normal. So more than actually using electro diagnostic modalities treatment, before we actually come to the treatment, it's important that when we do an electrodiagnosis, it's more for actually ruling out the differentials. So that is your peripheral neuropathy, lumbar plexopathy, and high lumbar radiculopathy. Treatment, non-surgical treatment is the choice for myalgia paresthetica. William and Thursell reported 91% of success with conservative management. Initial recommendations include losing weight, avoiding tight garments. If there is no response, then we can start with your TENS, and analgesics and injections are advised. Surgical intervention includes transecting the lateral femoral cutaneous nerve at the inguinal ligament to decompress the nerve. So LFCN block can be given before we go in for cryoanalgesia or your nerve radiofrequency, which can be pulsed or conventional. Peripheral nerve stimulation, and finally, if nothing responds, then spinal cord stimulators have also been tried. So this is a cross-sectional anatomy. You can see the probe there. I'll be showing the short axis images of how they, the lateral cutaneous nerve will be appearing actually. And here you can see there is the nerve between your sartorius lateral edge and the tensor fascia lata. So this is the transducer position for LFCN block, and that is transverse, inferior to the ASIS, and lateral edge of the sartorius muscle should be visualized. So as I told you that it is present between your sartorius and your tensor fascia lata muscle. So this is the lateral cutaneous nerve, the anterior and the posterior branches, and this will be the distribution of the nerve. So the equipments you require for the block, most of them are, because this is a very superficial block. So linear transducer, ultrasound machine, standard nerve tray block, syringe with local, and a small, short needle is sufficient with sterile gloves. Patient positioning landmarks, the block is performed in supine or lateral position. Most of the time it's in supine position. ASIS palpated. Transducer is placed 2 centimeters inferior and medial to the ASIS. Correct identification of LFCN may be made by eliciting a tingling sensation on the lateral thigh using nerve stimulator. Aim is to place the local between the two key muscles. Technique, the patient is in supine, skin disinfected, transducer placed inferior to the ASIS and parallel to the inguinal ligament. And both the muscles are identified. The nerve is seen between these two in the short axis. Needle inserted in lateral to medial position, as you could see in that. A pop or a click is felt, and 1 to 2 ml is deposited as a diagnostic. So there is other subinguinal technique, and in adults, a small dose. With even the children, you can use 0.15 ml per kg per side. So next we'll come to sciatic nerve entrapment. Sciatic nerve, a little anatomy about it. Sciatic nerve arises from the lumbosacral plexus, L4, 5, S1, 2, and 3 nerve roots. It enters the lower extremity at the greater sciatic notch near the piriformis muscle. 88% of the times the nerve exited below the piriformis. 11% the piriformis has divided, and you can see the both branches of the sciatic divided into separately. And 0.86% fibular and tibial nerves passed either below or above. And 0.13% of the time the entire nerve pierced an undivided piriformis. So here you can understand better. You can see the piriformis. The piriformis starts from the sacrum and it comes in, attaches to the greater trochanter. This is a posterior view. The nerve is passing below it, which is in 88%. 11% here you can see the piriformis is actually split up. Here you can see that it is either above or below. And in this, there is the piriformis is undivided actually in 0.13% of the time. The anatomical variation of the sciatic nerve is the commonest cause of non-traumatic cause of piriformis syndrome. So the fibular branch innervates short head of biceps femoris. The tibial nerve innervates the remaining hamstring muscles. Except for the saphenous nerve, the entire sensory and motor supply below the knee is by the sciatic nerve. That's the reason why when we give a popliteal sciatic block, we are actually supplemented with the adductor canal, in which your saphenous nerve is covered. So the etiology is it can be compression because of hematoma, abscess, piriformis syndrome, trauma, gunshot, laceration, fracture, IM injection. Again, something which is common, you know, and that's the reason also why we say that we divide it into four quadrants. And right upper quadrant, you can right upper outer quadrant, you're going to give your IM injections. Nerve ischemia, vasculitis, thrombosis, and idiopathic. Five common causes of hip five common causes are 34% of the time hip arthroplasty, again, nitrogenic thing. IM injection 28%, hip fracture 9%, tumor 8%, and external compression 8%. Sciatic nerve injury is the most common neurological complication in hip arthroplasty. From the incidence is 0.6 to 6.7%. Piriformis is less common due to sciatic nerve entrapment, but more due to direct trauma to sciatic notch and gluteal region. The signs and symptoms are weakness, impaired ankle reflex, paresthesia, sensory loss along the distribution of the nerve. Weakness of the toe extension, flexion, ankle dorsiflexion, plantar flexion, ankle eversion, and inversion are the most prominent ones which you will be seeing. The reason why you see this thing is because the sciatic nerve distribution is more, and below the knee, whole and sole, it is covered by this except for the saphenous area. Absence of complete weakness of ankle dorsiflexion, plantar flexion is a good prognostic sign, and early recovery can be done. Fibular affected more commonly than tibia. We'll be seeing why that happens. Why the fibular division gets affected more? Because it's more superficial and lateral, and blood supply, smaller blood vessels are existing, fewer and larger fascicles, less supportive endoneurium, tethering of the nerve with the fibular head and notch. Can be by your trauma, direct trauma to that area, because there is only a skin and subcutaneous tissue. Exceptions include gunshot and femur fracture. Both are equally involved. Both the divisions, fibular and tibial nerve, are equally affected. So we'll just touch upon piriformis syndrome. It is a pain which is encountered quite common. Piriformis pain in a pain clinic, deep buttock pain, squatting, climbing stairs, person pain, and compression of the parental nerve may also be associated. Because of that, the males can have scrotal pain and labial pain in females, and you actually can elicit tenderness over the area on deep palpation. Painful bowel movements can also be associated because of the proximity of piriformis with the rectum. Pain on flexion, adduction and internal rotation, that is your FAIR test. There are other tests which can also be elicited in this case. That is the Freiburg sign, pace sign, Beatty sign. All these in which there is a passive movement. Freiburg sign, you have the patient lying down on his back and extended knee and hip, and passively you're going to internally rotate, and the patient says he has got pain. Pace sign, the patient is actually in a sitting position. Beatty sign is in the lateral position, and abduction is more painful. Coming to the diagnosis, neuroimaging of the pelvis with the lumbosacral spine, always to rule out the other causes. So, electrodiagnostic studies are helpful to confirm the location. Piriformis syndrome, clinical exam with electrodiagnostic studies and neuroimaging. Treatment comes conservative therapy, include medication, injection, and physical therapy. You can, there are cases where spinal cord stimulator and intrathecal pumps for those optimal response. If there is suboptimal response, these have been considered. Surgery in those who have obvious mass effect, traumatic neuropathy. Surgery outcome better in tibial division than fibular. IM injection in piriformis with ultrasound guidance. has got under ultrasound guidance, the chances of you hitting the piriformis is much more. Botox has also been used if the injections are short-lived. Piriformis tendon release sciatic neurolysis is considered as a last resort, surgical resort. So, fibular nerve entrapment. Fibular nerve entrapment is the most common cause of the most common nerve entrapment of the lower limb. Second comes your sciatic. So anatomy is derived from the sciatic nerve, L45S1 and 2, approximately 8 centimeters proximal to the popliteal fossa. It separates from the tibial nerve. Two branches, the sural communicating and lateral cutaneous nerve. The lateral cutaneous branch is a sensory branch, winds around the fibular head, covered only by a uh, thin subcutaneous tissue. At the fibular head, the nerve is most vulnerable to injury. 1 to 2 centimeters below or distal to the fibular head, the nerves divides into the fibular tunnel. Dives into a fibular tunnel made by the soleus muscle aponeurosis and fibrous arch, which is quite inflexible. Most common mononeuropathy of the lower limb, as I told you, most commonly occurs near the fibular head. 83% of the cause is identifiable, 31% of that being perioperative time. Cause may be entrapment, compression, traction, trauma, metabolic, so hypothyroidism, diabetes mellitus, surgery, and idiopathic. It is postulated that the chronic nerve irritation causes edema in the tunnel, subsequently scar tissue formation as the nerve glides during knee flexion and extension. Deep fibular nerve compression 10 centimeters proximal to the ankle. This is also called as anterior tarsal tunnel syndrome because it is about 10 centimeters above the ankle, caused by compression beneath there is the extensor retinaculum below which it gets compressed. Signs and symptoms. As any other entrapment which we have discussed, there will be weakness, paresthesia, sensory loss, and pain can also be seen. Weakness of the ankle, dorsiflexion, and eversion of ankle is common. Steppage gait and foot slap can be there. Positive tinal sign. If the injury is proximal to the knee, weakness of the knee flexion because of involvement of bicep femoris can be there. And if the territory is not matching, then you have to also rule out lumbar plexopathy, radiculopathy, and peripheral neuropathy. So the treatment is non-surgical. Management in diagnosis is nerve conduction studies. EMG not only confirms axonal loss but muscle involvement. For dynamic neuropathy, electro-diagnostic study before and after exercise. Many a times there is at rest, maybe the patient doesn't have any on EMG, on nerve conduction, you don't feel anything. But once the patient has done an exercise, before and after, if you want to compare, then you get a better result. Neuroimaging may also be considered necessary because it is to isolate the cause. Treatment is non-surgical. Management include rest, food fare modification, analgesia, injections, physical therapy. Fibular nerve block is a diagnostic injection. Surgery is advocated if no response to conservative management in 2 to 4 months. Neurolysis and end-to-end suture repair, surgical management can be done. So this is the histological picture in which you can see the coverings of a nerve, how it is. There is your epineurium, which covers your nerve fascicles, vessels, connective tissue. Then there is your perineurium, which covers your nerve fascicle. There is endoneurium, which actually covers your axon. This is a histological picture. Nerve roots have 6 times the collagen that does by a spinal cord itself. Peripheral nerves have 5 times more collagen than these nerve roots. Blood flow must be maintained even when the nervous tissue is elongating, and this is ensured by tortuous vessels that allows them to straighten and unfurl when the nerves are lengthening. So when they are stretching also, the nerves, that's the reason why it is torturous. So it just doesn't get the third or torn apart. Nerve bound by epineurium and delimited by areolar connective tissue. This is the mesoneurium. Here you can see this is the mesoneurium. Here you can also see the blood vessels. Compression alters blood nerve barrier. So this is the proximal end, distal end. The nerve can be like cords. You can here you can see like cords, or you can see the plexiform shape can be there. Either ways. So this is of course I thought they just put in the two forms of how a nerve can be a cord like. Mostly in the proximal end it is like plexiform and distally it is like cords. So the basic pathophysiology is increased permeability of endoneural blood vessels. Edema is caused, increased in endoneural fluid pressure, further obstruction of vasculature and injury to the nerve fibers. Here, of course, it's a median nerve, but I thought for sono pathology part we can just add on. Here you can see that it is more hypoechoic and fluid and edematous. Fluid collected, there is edema, and this is in a short axis. This in a long axis, you can see that the nerves is quite edematous in this, and here you can see the exact location where the entrapment is happening. This is again a short and a long axis of a peroneal nerve or your fibular nerve. This is a short axis probe position and a long axis near the fibular head, which is very common to get injured. These are my references. Thank you.